Hello, I'm Teri Schreiner, a neuroimmunologist at the Children's Hospital Colorado and the University of Colorado. For me, the story of acute flaccid myelitis began in the late summer of 2014 when my colleagues and I recognized a cluster of patients with a distinct presentation of flaccid limb weakness with preserved sensation, decreased reflexes, and distinctive MRI findings. This syndrome was called Acute Flaccid Myelitis, or AFM. AFM is further defined by MRI lesions largely restricted to the gray matter and spanning one or more spinal segments. While patients with this constellation of symptoms had been recognized previously, these cases were occurring at the same time and during a peak in the number of Enterovirus D68 infections worldwide. That year, and in 2016 and 2018, we saw a peak in the number of these cases reported to the Centers for Disease Control and Prevention. With time, we identified AFM as a distinct syndrome that is one of the many causes of acute flaccid paralysis. However, AFM may mimic other causes of acute weakness, such as Guillan-Barre syndrome, myelitis caused by demyelinating diseases like acute disseminated encephalomyelitis, MOG-associated disease, and neuromyelitis optica spectrum disorder, and other infectious myelitis. The most notorious of these causes is poliomyelitis caused by the polio virus. Differentiating the type of acute flaccid paralysis has treatment and prognostic implications. While the treatment of AFM is supportive initially, with an early and ongoing focus on rehabilitation, surgical options are possible outside of the acute period. Furthermore, preventing iatrogenic harm through appropriate diagnosis remains critical. Of the confirmed cases submitted to the CDC, published after the 2018 outbreak, nearly all patients with AFM experience a febrile illness preceding the onset of neurologic symptoms by a median of 5 days. Respiratory symptoms are the most commonly reported, though GI or hand-foot-mouth symptoms are also reported. Weakness is typically asymmetric and tends to involve the upper extremities more than the lower extremities. This contrasts with paralytic poliomyelitis, which more often affected the legs. Weakness predominantly affects proximal muscle groups and ranges in severity from barely discernible weakness in one extremity to profound quadriparesis requiring respiratory and nutritional support. Sensation typically remains intact. However, patients may complain of a neuropathic pain in the affected limbs around the time of weakness onset. A minority of patients have objective evidence of sensory deficits in fine touch or vibration, presumably due to involvement of the dorsal horns. A third of those patients may present with cranial nerve deficits, including eye movement abnormalities, facial weakness, and bulbar weakness. A minority of these patients may also have cranial nerve or neck weakness without limb weakness. There is no apparent geographic clustering. The median age is 5.3 years and 94% are pediatric. 58% are male, and of those with complete data, approximately half identify as white. Patients with AFM have distinctive exam findings. They are, by definition, flaccid with decreased or absent reflexes in the affected limbs. Unlike many other causes of acute weakness, AFM can present with severe weakness in affected upper limbs and normal strength in the lower limbs or marked asymmetry. There is no specific test for AFM. The diagnosis relies on identification of distinct clinical, radiographic, and CSF characteristics. 87% of cases have an increased number of cells in their cerebrospinal fluid, with a median white blood cell count of 94, with a lymphocytic predominance. CSF protein may be increased. Electrodiagnostic studies show decreased compound motor action potential amplitudes with normal sensory nerve conduction studies. Red flags for consideration of other causes of acute flaccid paralysis. Albuminocytologic dissociation that would be typical of Guillain-Barre syndrome. Hyperacute onset, which would be more typical of spinal cord stroke. Progression of weakness to nadir longer than 10 days. Prominent sensory dysesthesia outside of the acute phase. Seizures and encephalopathy. The every other year pattern that started in 2014 has been interrupted by the COVID pandemic and social distancing. In absence of recent outbreaks of enterovirus, one prediction model would suggest that as the susceptible population has increased, seen here in blue, and the risk for enteroviral infections is increased, possible AFM cases have increased as well. We should all be attentive to these symptoms as we enter the summer and fall months. We are only one of a few centers in the U.S. providing multidisciplinary care to our patients with AFM. Our team is comprised of experts from neurology, rehabilitation, infectious disease, and psychology. We are also one of a few sites participating in research in this area. If you have questions or would like to make a referral to our multidisciplinary AFM clinic, please refer to the information provided. Thank you.